Ron.
My name's Tim Bradley. I'm a paramedic here in Missouri, down around Lake of the Ozarks area. I've been in EMS since 1990. I started as a first responder when I was 17 years old. So I've seen a lot, I've done a lot in that time, seen a lot of people hurt in various ways, men, women, and children. Through my training, I've also become a tactical paramedic. I went through extra training for that out of Massed Ambulance Service in Kansas City, Missouri. And I've been with Miller County Sheriff's Department Special Response Team for probably 2 or 3 years now as a tactical paramedic. And essentially what that is the civilian version of a combat lifesaver in the military, what's known in the military today. It's also kind of like the old medics, the old combat medics. You know, you'd see a man go down, they yell medic, and the medic goes running. Doesn't exactly happen like that anymore. We don't go running into fire. You know, we don't want to get shot. If I'm the only medic for my team, who's going to take care of me if I get shot? So a lot of things have changed in that time. It really depends on where you're shot and what the damage that's been done to what organs and what blood vessels. If you have been shot in a gunshot wound to, say, the throat, that's obviously got different structures that you've got to worry about. The carotid artery, the jugular, even the airway, which are major things compared to if you got shot, say, in the wrist. That's not near as major an area. You can still function, and that's more of a survivable gunshot wound than, say, one to the throat or even to the head. It also depends on the caliber of the weapon. A lot of people have asked me what's out there to help stop bleeding. Is there some little chemical or something that I can buy? Believe it or not, this is called Quick Clot. This is available for purchase over the counter. There's another product called Traumadex available. Quick Clot, I bought this in Jefferson City at a place called AllMed for $25 for this package. It'll last 3 years on the shelf with this on the shelf. Outside of this package, it'll last for a year. It's great for major bleeding. If you get somebody who's got an arterial bleed, squirting all over the place, the way they tested this stuff, they took pigs, completely cut their femoral artery in two, dumped this in, applied direct pressure for a while, for about 5 minutes, if that, took the dressing off, washed this out, and the clot held. Now, I'm not saying you do that. You know what I'm saying? What you do, you got somebody with a bad bleed, rip this open, dump it into the wound, apply direct pressure, bandage over it, and then when personnel show up to take them on to the hospital, say, hand them the package, the leftover package, and go, this is what I did, and tell them. This stuff is, like I said, it's available to anybody over the counter. Police officers on tactical teams carry this. The U.S. military is currently using this over in Iraq and Afghanistan with a lot of success. There are, however, drawbacks. It does burn a little bit on anything liquid, so you want to kind of wipe excess blood off if you got a chance. It'll cause some burns, minor burns to the skin. Also, if you dump it on intestines or mucous membrane type areas like the nose and mouth, it'll cause bad enough burns to, like your intestines, you end up losing that section of intestine. So, like anything else in life, it's got its good points, it's got its bad points. If it's down to me dying or living because of this, I don't care where the wound is. If you think it'll help and it's me laying there, you better dump it in that wound. Please. A lot of it is the mentality of the person. If they watched a lot of TV and they see a guy get shot once and they think, oh, well, I've got to die. The mind can cause you to die. You can literally talk yourself into dying. Whereas some people who have been involved in shootings or other violent confrontations, they just are determined not to give up. The fight or flight kicks in, and they fight for everything they've got, and they just survive. They will not give up. And part of it too, the human body is an amazing machine. It's so well engineered by whatever created it. I saw a 15-year-old with both arms turned into literally hamburger, and she was still able. From the elbow down to the wrist, you could literally see her joint on one thumb, and she was able to move all of her fingers. And just that amount of determination in the human spirit can really drive a person on. And it's the human body will also create its own morphine and Demerol just on its own. So people don't realize they're cut or shot or whatever injuries they may have, and they're still able to function and move, maybe at a lesser capability, but they're still able to keep fighting on. Because the better physical condition a person is in, the better their body can cope with illness and injury. A person who has more muscle mass, a bullet has more tissue to travel through, and muscle's a little bit heavier than fat is. So someone who's got more muscle mass, it's a denser tissue, and the bullet's going to have to fight harder to get through that tissue. Whereas someone who's got more fat, the bullet will zip right through that quicker than it will. Plus, the more muscle tissue that you have, the better you can fight on. So a person who is in better physical condition, even though they are injured, that limb on someone else may be, down to 25% of usage. Whereas someone who's got in better physical condition, it may be 50. It can literally be, say, a cut to the throat, where the jugular and carotid arteries have been slashed on both sides. It can literally be less than a minute. So you literally will have seconds. Of course, if that's done, you've also got a lot of musculature and a lot of the tendons and connective tissues. So if someone's literally, their head's almost taken off, almost decapitated, again, it can literally be seconds. And with injuries such as that, it's really not the bleeding out that may get them. If it's a cut to the throat, to the carotid, it may be an air bubble getting inside that, because you've got a very large garden hose going, and you may get an air bubble up in there, and it causes an air embolism, and it looks a lot like a stroke, and that can kill you just as quick. So the best bet there, if you get a little bit of a cut, it's not, is take your hand and just slap it up there, and that may buy you enough time. It may keep you from getting an air embolism up there. If you happen up on a scene and you do that to someone, the problem is you're stuck there for a while. Mm-hmm. What we'll do if we have the opportunity is we'll tape on a occlusive dressing, same with a punctured lung, to keep a lung from going down. It's a dressing to keep air from getting inside there. Wounds to the aortic, the abdominal aortic blood vessel is, it can literally, again, be seconds. So some of these people who have injuries to these areas really don't have a lot of time. Other people, though, it may be hours. It just depends on what's going on and what their body's doing at that time. And some people will survive slash to the throat. Some people will survive having a triple A. Or it depends on where the slash is and where the stab is. A slash to the throat can be lethal, whereas a slash to the back of the arm or to a limb isn't always lethal. Even cuts going this way to the wrist is not a lethal cut. There have been several suicide attempts that they cut across and it does nothing. You bleed a lot, but the way your blood vessels are constructed, they constrict on their own. They can even shut themselves down. The arteries can also close themselves off completely. A stab would be more lethal because a lot of times you think of a stab going into the center mass or torso area. And it's a smaller hole. It doesn't, a lot of it is, it's deceptive. You look at it and it's like, well, it's not that big a deal. It's not a big hole. Whereas it's not necessarily the outer damage that you see, it's the internal damage that's done. Same with gunshot wounds. You know, it may not look like, you know, they may be shot with a .22, but because it's the damage that's done on the inside is what you've got to worry about. You may have a stab to, you know, here on your abdomen, but, you know, you think it's no big deal until you start feeling dizzy because your liver or your spleen has been lacerated and you're bleeding out. When you have, that's called an evisceration. When you have that, the intestines may come out. They may even protrude partially out. You may see part of the liver or other internal organs protruding out. And usually the best bet with that is not to poke them back in if you can keep from it. What we're taught to do out in the field now is to take a sterile dressing and soak it with water, a moist sterile dressing, and place it over that, and then put an occlusive dressing over that. And we actually carry saran wrap and aluminum foil to take care of patients on the ambulance. And a lot of the stuff we carry can be, a lot of the treatments for out in the field can be taken care of with a blanket, saran wrap, aluminum foil, and duct tape. And it's amazing. One of my instructors, paramedic instructors one time, he was an old medic, been a medic for years, become a nurse, asked our class one time, if you could take one thing onto a scene with you, you're only allowed to take one thing, what would it be? Everybody was saying the oxygen tank, the bag. Well, what one thing would you want to take out of the bag? What one thing would you want to take out of the ambulance? You know, well, my stethoscope, this, that. Nobody said the next thing I'm going to show you, and this is the most valuable tool that you can ever have in your car, and it's a blanket. A simple blanket. I can use this as a bandage. I can turn this into a splint. I can keep my patient warm with this. I can move them with it. I can do whatever I have to. A lot of things that I have to do with this. You know, the big trauma pad, it comes out to about that size. Oh my Lord, it'll cover the chest. I get a lot of holes here. I can do the same thing with this that I can with that, all the way down to that little eye patch. The splints, I can fold it up, wrap an ankle with it, and splint it with that. I've splinted ankles with pillows. There's a lot of stuff you can do with just everyday items. If you're a police officer, your buddy gets his arm broke, you've got a wonderful splint already on your back belt. And just wrap it up. If you have to do it that way, if that's all you've got, it'll work. Okay. The sticks that we have, the rattan sticks, put one on either side, that'll make a splint. A splint is anything that's somewhat solid. You can use a magazine to make a splint. All kinds of stuff out there. Been hurt, and he's been cut from here to here, and he's got everything poking out. Don't try and shove it back in, okay? I'm going to take my handy blanket here. I'm going to soak it with water. I'm going to cover it up with a wet, sterile dressing, preferably. If you don't have one, use whatever you got that'll work, okay? Then I'm going to take saran wrap or plastic wrap. Doesn't even have to be that. If all I've got, notice everything I've got over here is in plastic. I will take one of those plastic bags, cut it up, and paste them, tape them together, and I'll put it over this. That's to kind of keep that moisture in there, okay? It can be anywhere from, depending on where the cut is, it can be anywhere from, 4 to 5 liters, 4 to 5 liters, which, 4 liters is shock, and or even death, and you've only got, I believe, 6 liters of blood in your system, and it could be anywhere. It can also be a few milliliters. Just basically imagine taking one of your kids' syringes that you get in the grocery store now to give them medicine. Fill one of those up and sling it, and that may be all that splatters out. If it's just a straight stab in and out, again, be aware, he may have bleeding underneath here that you can't see. There's not a lot of blood, and it's like, oh, what's going on? Now, if it's to the chest wall, you got a whole nother problem. Remember I told you about seeing this, your windpipe sitting here going left or right? They got a lung going down. They got a lung trying to collapse. Cut their shirt up and find that hole. It may be a lot of blood, it may not be. First thing you're going to want to do, and if any piece of plastic will work, okay? They've got occlusive dressing specifically made, and there's stuff out there on the market that you can buy specifically for that injury. But let's face it, that costs money, and if you're like me, you're not always rich, okay? So cigarettes is what they used to do in Vietnam. You can take a plastic bag, you can take anything. So if he's got a hole here in his chest somewhere, all I'm going to do is I'm going to take, and even this piece of plastic will work, I'm going to take this piece of plastic, put it over the hole, and I'm going to tape it down on 3 sides. All right? You don't want to tape it down on all 4. Reason being, that lung's trying to go down. What's happening is it's sucking air in through there, not letting air out. You know, you only want the air to come out. You don't want it to go in. So all you're going to do is you're going to tape it down here, here, and usually you leave the side that's pointing up open. So, you know, tape it down on the 3 sides. And what will happen is that'll act like a one-way valve. So when they breathe out, air will come out. But when they breathe in, it'll suck back down to the chest, and it won't come back in. And that'll kind of be, it's more or less a delaying factor until you can get them to help. Like the person gets stabbed and the knife's still in there, don't take the knife out. Leave it in there. Don't sit there and go, start moving around on it, tugging around on it. That's bad juju. If he's conscious, he's going to hate you. You know?
Same thing with a bullet. If you see the bullet, you should try it.
Yeah, same thing with a bullet. If you see the bullet down in there, don't start digging around with forceps or tweezers or anything trying to get it out unless
even if it looks like it did come out easy, you should.
I wouldn't. You know, if it's like a fragment just on the skin, then yeah, you might be able to pop it out. But if it's, you know, if it's down in there a little ways, especially in the chest cavity, because that may be plugging the hole and keeping his lung up. You know, and maybe, you know, you never know. But with especially with the knife, leave the knife in there. Don't move it around too much. What you'll do is you'll take your bulky dressing, your blanket, your big trauma pad dressings, Curlex, whatever you got, roller gauze. Put it around that, kind of stack it up, tape it down, and immobilize that protruding object there, and keep it there. I would say 99% of the time. Now, the 1% of the time it's not is if it's interfering with your airway. Because in the medical system, the way we're taught now, we're taught airway, breathing, and circulation are right at the top in that order. You know, and of course that's after scene safety. So if you've got an impaled object, say in your cheek or in your throat, and it's interfering with the airway, and you can safely remove it, especially if it's here in the trachea, if you can safely remove that object without, you know, nicking any arteries, if it's, you know, been that precise, then yeah, remove the object. Otherwise, leave it in, because you may be doing more damage than taking it out than leaving it in. A lot of times what has happened is it's in there and it's plugging the hole right now and keeping that bleeding from happening. And it may actually form a clot around that and stopping the bleeding, so the person is actually better off. So yeah, don't ever, if you've got an impaled object, don't ever take it out. You know, it's, you know, and best bet, what we do out in the field with an impaled object is if we can transport it in the ambulance without it being a problem, then we'll put a bulky bandage around it and stabilize it to the person and keep it from shifting around, because if it shifts around and moves around too much, it'll do more, again, more damage, because you've got to think, you've got this blade sticking in here, and all you see is the handle up here, and if you move that around or anything, you're cutting all the tissue lying underneath. Another place that you can use a piece of plastic and occlusive dressing is cuts to the throat, especially to the artery here, the carotid artery. If you get a cut here, yeah, you're going to bleed a lot, and it can be a life-threatening bleed, but it's just as threatening because you've got a big pipe here that's leaking blood, but it's also open to air. You can get an air bubble in your throat and get an air embolism going up into your brain, and that is just as lethal. So if you're ever in a combat situation, you're fighting, you know, and you get tagged right across the throat, you see blood starting to squirt like that, take your hand and slap it up there and apply pressure yourself. Buy yourself some time. Again, you're a one-armed fighter now, but at least you're buying yourself time, and try and cover up the hole as best you can completely. Okay? Now, if you walk up and you see a guy just standing there going, yeah, and it's your friend or, you know, somebody that you've come up on, you can take your gloved hand, put it up there, and try and bandage it as best you can. And again, occlusive dressing if you can. You know, just whatever you can to keep an air bubble from getting up in there. And that air embolism, again, is just as lethal and just as dangerous. It sounds complicated. If I walk in and I see a guy sitting there and, you know, he goes, hey, how you doing? Well, guess what? I've just assessed he has an airway. He's breathing. Because if you don't have an airway, you can't breathe. He's got circulation. Because if he didn't have circulation, he probably wouldn't real good circulation. He'd probably be passed out. So I've just gotten those three out of the way. Now, if I walk in and he's laying there on the floor, okay, my job's just gotten a little harder. So I get down, look, listen, and feel. You've got everything. You could be stripped naked, have no clothing, nothing. You've got all the tools you need in your five senses to do a patient assessment. It's not that hard. You walk in, you look at your person. Is their skin color normal? Yeah. Okay. Their circulation's good. If it's pale, okay, something's wrong. Why are they pale? If they're blue, okay, that's a lack of oxygen. You know, that they're not getting enough oxygen. They're not getting enough air. How come? Try and figure out what the problem is. If it's an airway problem, if they're not breathing, try and open the airway. Kevin, if I could borrow you. The way you do that, just go ahead and lay down. The way you do that, say I'll come in, Kevin's out. He's not, you know, I come down here, I look, listen, and feel. I put my hand on his chest to feel if there's any chest rise, and I watch to see if there's any chest rise. I'm feeling for air on my cheek. I'm, you know, looking at him, looking at his color. He's not breathing. I can't get it, you know. Okay, why is he not breathing? Well, a lot of times the tongue will block off the air back here in the back of the throat. So what you do is a simple jaw thrust maneuver. They used to teach pinch the nose, and well, if they've got a cervical spine injury, you know, and there's any chance of saving them, you crank around on their neck, and they've got a broken neck. Guess what? They're done. They're paralyzed from the neck down if it doesn't kill them. So a simple jaw thrust. Come in, find the angle on their jaw, put your thumbs on their cheek, and you just lift up. And it'll pull the jaw up and the tongue up, and maybe give them air. You do that, you look, listen, you know, and then they start breathing. Okay, you figured out what the problem is. So now you need to figure out a way to open up their airway. Okay. Now, if you're out in the middle of nowhere, you can't stay out like this forever without going to get help if it's just you and this guy. There are airways that you can get, but without the proper training, you really can't, you know, unless you're specifically trained to use an oral airway or a nasal airway, you really can't use them. So, at this point in time, you got to take a risk and take a chance. Your best bet, you know, pull his arm up here, put him in what's called a recovery position. Roll them up like that. Hopefully that'll keep their tongue off the back of their throat. Also, if they vomit, it'll let that drain. And it'll buy you time to go to get help. You know, if I think he may have had a neck injury, grab here, hold C-spine for a little while if I can, if he's sitting up. If he's laying down, you do the same thing. If you can hand this off to somebody, do it. Then from here, head to toe assessment. All you need is your 5 senses. I'm touching, I'm looking at my hands for blood, feeling for broken bones, anything protruding, any lumps, anything that doesn't belong, feeling along the neck, again, feeling for step off. If I feel along here and there's something that's kind of crunching in there, don't sit there and go, well, what's that? Especially if it's his neck. If it's broken, he's going to let you know. Feeling along here, feeling for anything out of place. The arms and legs, you want to do one at a time. Don't go down both at the same time, because he goes out, you're going to be like, which arm did he break? So what you do, you come down here, feel this one, come down here, feel this one. Stick your legs out straight. Or actually, go ahead, kind of lay down. Okay, look at the pupils. Don't take your real high-powered mag light or, stream light or whatever. Get a regular pen light. You can use some of the lower-powered stream lights, some of the lighter, softer lights to check the pupils. And both pupils, when you shine a light in one pupil, they'll both react. They'll both constrict, and then they'll both come back up. So you shine it in both eyes to make sure that they both work like that. If you see one kind of go down and the other one stay big, you got a problem. He's got a head injury. Now, here's the funny thing about the eyes. If your patient's right pupil is blown or really small, if it's really big or really small, but the other one's reacting, the injury is not on the right side of their head. It's on the left side. Reason being, everything in your brain is crossed in a way. So if I've got say if he's got weakness on the right side, the injury's on the left side. That's where the problem is. What can you do out in the field to maybe help you? Well, roll him over onto his affected side and kind of keep blood from rushing up to that area. Kind of let gravity help you. Let Mother Nature do some work for you. If he's got a C-spine fracture, they've got cervical collars that can be bought. A lot of the ambulance services carry them. But if you don't have that, you've got to worry about immobilizing his neck. There's a lot of tricks you can use. First one, you can make a C-collar out of a towel. Take it, just fold it a couple of times. And you can tape it up. Just kind of slide it in under here real gentle. You don't want him to move his neck. And it's not going to keep him from moving his neck a whole lot if he chooses to. It's going to be there more or less as a reminder. And you can tape that up, and that'll kind of help him remember, okay, I can't move my head. Smell bad. Now along with take the toes, put them along the side of his head. Right like that. So you've got this taped up here, you do that, and that'll act kind of like more of a splint to remind him, don't move your head. So you just kind of tape them down like that. Especially if you've got a cot or something, you can tape him to. Yeah, strap is fine. Feel along the chest. Again, what am I feeling for? I'm feeling for bone going crunch. And it'll sound like, just imagine two boards in a shirt grinding against each other. If he's conscious, he'll let you know it hurts. But I'm feeling for that. To us in EMS, a naked trauma patient's a happy trauma patient. We cut clothes off everybody. So we'll cut their shirt up, and I've had people get upset with me because I've cut their favorite shirt or dress off of them. It's like, sorry. But I'm also looking for what's called paradoxical movement in the ribs. If I've got 3 ribs broken in, say, 2 spots, you'll actually get movement. The regular movement of the ribs is like this, breathing in and out. Paradoxical movement, the part of the section, a flail segment is what that's called, will actually move the reverse. So when they breathe in, you'll see that section of ribs that have been broken away go suck in. It's very dangerous. It's a life-threatening injury. And the way we take care of that is we take a pillow splint and we tape it to their chest. Used to we use sandbags until we figured out that's probably not the best. But a pillow splint's about your best bet there. We come down, we look at the abdomen, we're looking for bruising. We're feeling the abdomen. Is it soft? Oh yeah, it is. But if they've got an injury there, or they're guarding it, it's going to feel like you're pushing on a rock. And if they're pale, cool, and diaphoretic, this guy's got some bleeding going on somewhere in here. He's got a hot belly. He's got something going wrong here. We got to get him out of here and get him to a hospital quickly there, which is the next area to inspect. What you do, push in, push down, right on the pelvis. And usually the pelvis is a big circle, okay? If the pelvis is broken in one spot, it's usually broken in another. You can't break that circle without it being broken in two spots usually. And that can be a big problem area if it's busted. It's a hard bone to break too, just like the skull is. I think it's within the top 5 bones as far as how hard it is to break the pelvis. But again, you just push in, push down. On guys, this is going to sound embarrassing to some of you. Look and see if they've got an erection. Okay? It's not like we're all going, oh, no. What that is going to indicate and tell you is he's got a head injury or a C-spine fracture. It's what we call a priapism. And it's basically, all it is an erection. Man having an erection who has another problem. It's a neurological problem. And it can be life-threatening sometimes. Looking at the legs, the femurs. If you get one femur broken, you can lose quite a bit of blood in it, but it won't kill you. You may lose that leg. If you have both femurs broken, you can lose enough blood in both femurs to kill you. Okay? So if they've got both legs broken up here, that's a major problem. So you feel along here, again, feeling for crepitus, looking for blood, any major bleeding. Come on down to the knee here, check the lower legs, check down through here. Okay? Check the feet. A lot of times we take their shoes off. Treating for shock out in the field for even the lay person is lay them down, put their feet up, put their head down, literally have them in a position where they're almost, if they're laying down on a bed, have them where their head's pointing downhill. That's the first rule if they're in shock. Keep them warm is the second thing. Also, if you can control any bleeding, control it. If, apply direct pressure if you've got the opportunity. If it's a combat situation, you don't have that time you can't apply that direct pressure because you're obviously got other problems going on. So in the tactical setting, what we would do is we would apply a tourniquet for the time being until we can get that person, if it's to a limb. If it's to the core, or if it's a major bleed that we can, we will get them out of the situation, get them out of the hot zone until we can apply pressure dressings and apply those dressings, apply everything else. Keep the person still, keep them quiet, try and calm them down, talk to them. That can be a big thing. You can do a lot just by talking to a person calmly and calming them down. The calmer they are, I want to touch on real quick is triage. Triage is simply the sorting of patients, the sorting, categorizing them so you can see, give the ones who need the care immediately, get them care. The ones who really don't need it, you can sort them and push them over here off to the side and say, you're okay for now, but we're going to get to you as soon as we can. If you're the only one who's medically qualified and you've got 5 patients there, you're probably going to have to start doing triage. Okay. The one, the classic example of that is, say, I'm with the TAC team and we're going through, and next thing you know, boom, there's shots fired, and I've got 4 guys that are, one's been shot in the head, he's been shot in the head, he's down. You may be sitting there, shot in the chest, you're still alive, but you're hurting. Okay, you got a lung going down. The next guy, Chad there, he may be, just nicked in the arm. The next guy, you, may be sitting there, and because
he got shot in the head and you got splattered with it, you're just freaking out. You're over here with him going, you got a medic, come here, God, you got to help him, he's still breathing, he's still alive. You know, these people will be trying to grab you and drag you over to that person, okay? Here's the thing, he's dead. He's got brain matter showing. Even though he's still breathing, if he's not my only patient, you know, if he's not your only patient, you may have to look at him and go, sorry, man, step over, you know, say a quick, what I've always done, say a quick prayer, God help you, God be with you, God forgive you, step over and go on to the next guy. You know, the next guy may be shot with, you know, a lung going down. I can save that guy. He's the one I'm really going to have to worry about. Well, in the meantime, this guy goes, okay, you know, he's also written him off. He may be going to the guy with the shot arm trying to drag me over to him. Shot in the arm, you know, broken arm, something like that is pretty minor compared to a lung going down. So in your first responder classes, a lot of times you're taught triage and how to classify.
If you hit an artery, and you've got 3 different types of bleeding: capillary bleeding, venous bleeding, and arterial bleeding. Capillary bleeding is when you cut your finger, you know, just on the outer skin, the skin's broken, you got a little bit of blood, it just more or less oozes out. Venous bleeding, where you're coming, you know, you get a vein that's bleeding, it's not under pressure, there are valves there in the veins that keep blood from flowing backwards, and it just kind of flows out at a steady rate, and you can recognize that fairly easily, and that's not near as lethal. You know, capillary bleeding is usually not lethal unless you get a severe infection, and you're a long ways from any kind of medical care to take care of that infection. Venous bleeding usually, again, it's not as lethal as what the last one is, and that's arterial bleeding. And arterial bleeding is a bright red spurting blood. And you can tell it's squirting out. It's the equivalent of taking a large water gun and pumping that, and that's how the effect will be. And that tends to throw a lot of people off. Even in the healthcare profession, it's sometimes startling.
If you walk in, and even me haven't done it for as long as I have, I've ran calls where I walk in and I see something so god-awful horrid that it's distracting. If it's distracting to you and you can't function, cover it up. One case in particular that I remember, we had a lady who shot herself in the face with a .357, and all this was gone. It was mush. And here I am, she's still alive, still breathing, barely, and I'm fighting to say, you know, to do everything I can to get an airway on her. And I'm down here trying to intubate, and my elbow is right over the hole, okay? And I'm right down here, and of course I'm seeing all this at the same time, and I'm smelling all that, and it's distracting, and I couldn't function. So guess what I did? Took a bandage and just covered that up. For some odd reason, then it's like, okay, it's not as distracting. I wasn't afraid of getting my elbow down in that hole and dropping down in there. And I felt better about dealing with that situation. There was a flight nurse who had a patient that hit a fence right across here. Both eyeballs were laying out here on his cheeks. She had the same situation. She had to do just cover it up because he was looking up at her, you know. His eyes were just staring right up at her, and she's like, I can't do this. She covered it up. So if you walk in and you see something that's so just, God, you know, cover it up and move on.
If you have the opportunity to take a first responder class, by all means do it. It's a step above regular first aid. You learn a little bit more. It's more accepted also nationwide and even in foreign countries. And they go over a lot of stuff that we go over in emergency medical technician classes, which is the basic requirement to work on an ambulance. And it's only, here in Missouri, it's only a 40-hour class, and it will get you set up on what, you know, get you thinking of what you need and what route you need to go as far as what you might need to carry in your vehicle. And I believe you're still, if you can't find a first responder class, find a first aid and CPR classes. And those really go a long ways and keep the certifications up.
The flight of bullets after they hit our body is very fickle. It can go in the arm, up the bone, across the chest, out here, into this arm. They're incredible stories of the flight paths of bullets when you're shot. And so it is important that you learn how to shoot one-handed with. Now, on this same subject matter, I want to mention that many times professionals and citizens who are doing concealed carry are knocked down or shot, and their strong side is wounded. And they'll have to not only shoot from their left side, they will have to draw from their left side. Herein is the problem with the retention holsters. Many of them will not allow a left-handed pull in a variety of positions, and you have to be careful. Remember to weigh your need for a retention holster with your need to worry about having your gun taken away in the equation of how fast your draw is in the different situations. Are you more concerned about getting your gun out fast or more concerned about the enemy taking your pistol out of your holster? That's your personal decision, and you're going to have to weigh that out. But just keep in mind that if you're shot on your right side and you're on the ground or standing and you reach and you have to take your pistol out with your left hand, well, there are some retention holsters that don't come out this way. They come out back and this way, and turn this way and that way, whatever the design of the holster company and the retention level. So worry about this. Not only shooting with your weak side, but drawing your weapon from your weak side. And if you're struck and knocked down, you'll have to draw or shoot, possibly left-handed, from a ground fight position. And so here again we have this retention holster problem. And sometimes if your good hand is working real well, you may have to lift your hip up to get the right whistle and bell to turn to get your retention holster to surrender the weapon to you. And so don't be the guy who discovers after he's been shot and down that he can't pull his gun out due to his retention holster on the ground. So worry about this. Another thing I'd like to talk about, this has been an experience that I know several of my friends have been, is that sometimes it's not a bad idea to have a lanyard attached to your weapon, because as you fall or shot, your gun may go. And there's been several occasions where friends of mine have grabbed the lanyard and pulled the weapon in back to where they could get it again, because at that sudden baseball or baseball bat impact upon the body, their pistol goes flying away after they've been shot. So backup guns are a solution, but also you might consider the lanyard. The lanyards run from the holster to the weapon, or in some military or professional outfits, they'll have lanyards that are attached to different body parts to the weapon. This is a security and retention value that you can haul your weapon in when you've lost it from being shot or knocked down. If your primary hand is wounded, you're going to have, and you're down to one arm, you have reloading issues that I want you to think about. This semi-automatic and other semi-automatics lock back when the last round is fired. So what a lefty will have to do is access the release for the magazine. In this case, it's on this side. And my gun, this is my retirement pistol that they gave me when I retired. It's been worked on by a very good gun guy named Steve Camp. And one of the things I noticed when Steve's magic touch was done is when I touch that magazine release, this thing pops out like there's a little rocket in there to push it out. Many weapons, especially dirty weapons with sand and grit, won't get that release, and you'll have something stuck in here. So now, if you're one-handed, you've got to catch the lip of this magazine in some way, even if it's with your teeth, and draw that weapon out. You can do it on your clothing, you can do it on the belt, you can do it on the corner of a building. And if we were two-handed, we just rip the magazine out. But if this hand is done from a gunshot wound, you've got to figure out a way to get that magazine out. Worry about this. See how your release works. This works real good for me until I'm in Iraq or the sand or falling into a mud stream, and then suddenly my magazine is not so quick to come out. We've talked about this in prior levels. So you've got to get this magazine out. Now, to reload, and this arm is dead. You could be seated, you could be standing. Couple of different positions that you can use. Some people put the weapon in their armpit, take out the next magazine, seat at home. Or you've got to find the apparatus on your gun. This is really a right-handed weapon. But you see, there's the release for the slide to go forward, which also feeds the bullet into the chamber. So you see, you can have an armpit catch. You can feed it into here. Also, people will put their guns in their leg, the bend of their leg like this, and stick the magazine, take it out, hit the release, and go. Or you can put it any way that you want if God has given you the time to do this. But you have to suddenly realize that with one hand down, even if it's this hand, you're going to have to perform all these reloading functions with your weapon with one hand. And I want you to worry about that, think about it, work on the range. If you have a revolver, you can eject the shells pretty easily, but you have to load the revolver one bullet at a time, or get real good with your speed loaders to do this. End of the story is, get your gun, get your speed loaders or your extra magazines, and try to reload your weapon with one hand, right-handed and left-handed, and come up with some personal contingency plans in case this happens. You're suddenly wounded, right or left hand, and you've got a problem. You've got we call these stovepipes, you know, where the shell doesn't eject. This is the common malfunction, shall we say, of this weapon. And now, before, you would take your left hand and free this up, except now your left hand was blown off by an RPG. Or you've taken several rounds to this side and it's dead. Many people, here's our sight right here. Many people will access some solid object, such as this, and try to drive that all the way down, and with the hopes of the next round going into the chamber. And so you find a hard surface. Your belt is typically your most handy one to remedy the situation and clear a jam, send a round home, this type of thing. Again, get with your weapon. Revolvers don't seem to have this problem. Get with your weapon and try to figure out what you would do without a left hand and without a right hand to clear such a malfunction. Are we on?
We're on.
When you are evacuating, there's three conditions. There's no fire, light fire, and heavy fire. And we all hope that we're in a no-fire situation where we're trying to treat and evacuate one of our wounded comrades. But if there is the need for suppressive fire, remember, these things are not like in the movies where you have 62 rounds in each one without reloading. They have developed, for the last few decades, a periodic, you might say, cadence suppressive fire that you may grab your person with one hand or by the scruff of the shirt or wherever and haul him away from a hot or semi-hot situation by using a cadence fire. In other words, if I only have so many rounds and I do this, boom, 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 I'm empty. But if I have a periodic fire, boom, and then the enemy thinks he might pop his head up, boom, and he thinks it might happen again. Boom! Look at the distance I've traveled with a suppressive cadence that keeps the opponent down from shooting at you. So when you're doing these drills, think of that concept of suppressive fire delivered at a special rhythm.
To explain what I'm doing, it's just probably maybe better to show it. What we have is a product, another one of our products that TAC Arts is developing is we call it the Life Leash. And what it is a tactical environment rescue harness for very active shooter scenarios, stuff like that. So the idea is if you have a member down, traditional techniques require one of the guys unloads his weapon or drops his weapon or whatever, scoops the guy up and drags him out. If it's a team or something like that, they got guys covering them, you know, whatever. But if I can get a volunteer to... What this product here is going to do is if we got somebody down, I come in, much like the same, come in, scoop, very quick, release. Now, here's an optional mechanism here that I can reach down, fasten to his belt, something like that. What this does is it prevents it from riding up on his chest. Boom, I'd cinch it back here. Boom. Do a quick engagement and then boom, I'm back on. And then what we do here is now we have a tactical evac and I have another gun in the play instead of taking me out of play. So when you can see, how much do you weigh?
225.
225. I weigh about $180.
If you recall back in our earlier gun DVDs, we talked about the necessity for having rope. And you could have much thinner, smaller rope that has a great capacity for weight. But you can tie this around the armpits of someone, tie it to their belt, and use a makeshift device to haul a wounded person away. And so it's always good to have some rope of some type with you. And we know that a blanket is irreplaceable. You remember Tim Bradley referring to having a blanket and cutting it up for bandages or folding it up as a splint. Many, many uses. This is actually an old Army blanket of mine that's 30 years old. And it opens up quite big, and it even has the smell of a 30-year-old blanket. It opens up quite big, and what you would then do if you were alone is get your wounded person on top of this and come on up a little higher. And under some circumstances, this could be an emergency pull on this person. In fact, get up there so that your feet are not touching the ground. And so I can pull him away, presumably pretty quickly, a one-man pull. With a weapon, I may be able to pull him and fire and give some suppressive fire to get him out of the way. If you're lucky and you have two men, you can do a two-man blanket pull, and it's much more efficient. Getting him to cover. We're trying to get him to cover or to the best cover and medical attention combination as possible. He could have a pistol, I could have a pistol, and we could do much with your common blanket. For this two-man evacuation drill that we're going to do, I will take my gun, or essentially the head guy's gun. You got a top side and a bottom side. But this is a rapid evacuation of this person. You take your gun and stick it right about here so you can get access to it. Then we have our top side guy come around, and he is going to scoop under the shoulders. Our bottom side guy comes in and pretty much works to the point where he's going to take his shoulders and get them in the bend of the leg. And so everybody lifts up. And so he gets in, and this is an easy carry for him. Our top side guy has access to his gun, and either hand will allow him to get access to his pistol. Now, one of the two is going to be walking backwards in this configuration, unless you could turn around. Pivot, turn around, and grab his ankles. And now you see an excellent ability to go forward or back. He, if he needs to, draws his weapon out. He can shoot, and this is a much quicker way to make an evacuation. Now, what we're going to do is talk about some range of fire and shooting skills under no fire, light fire, and heavy fire out in the field. This, of course, is a no-fire situation, but their guns are at the ready, and they're capable of moving this person quickly to more medical attention or better cover. Just walk across the room there like that. If your enemy is that way and you're concerned about turning your back on the enemy, you're going to have to go backwards this way. Keep your eyes and guns in the direction of enemy fire. Okay. Here is a simulated stack without them having to hold him up while I'm making this speech. That was what you just saw as a no-fire situation. On a light fire situation, and how I designate that and how I wish you would in training is you have sticks and you suddenly have a light fire cadence. That means that someone is taking some shots at you. And so what we would do here is the foot guy would abandon the legs, pull out his gun if it wasn't out already, and set up, move off to the side, the most advantageous side due to the situation, and set up a field of fire while the back guy, who's still hooking, now hook the arms, will now solo drag this person off into some situational solution, however far it is, without abandoning him. In fact, he may fire and slowly move back. So you might say this is the light fire solution to this. Because now the next thing we're going to take a look at is going to be heavy fire. And this means that he's just going to drop him.
You're done.
You know, now we need both guys shooting, and theoretically, both guys have their guns out so that they can shoot. But this is so bad that both these men are going to have to take up a tactical position, and he's just laying there. He's just been abandoned. Legs first, don't bang his head when he hits the ground. But remember fields of fire. If one guy, you know, if he is shooting from this angle, the head man, the second man, must come over here and shoot from the other angle. They can't be two together. You're missing great strategic fields and ranges of fire. The head guy, if he's over here, the back guy should open up a good field of fire. Remember, if I can't see an enemy that's over here from here, he can from over here. So the wider you get, the better chance you have of killing the enemy. I will, as the instructor, initiate the heavy fire this way, as opposed to this, light fire, to heavy fire, and then you go into that major tactical position where both guys take up position. Go.